Welcome to Willow Health Media. My name is Dr. Mercy Korir. This is Lifeline Dialogues, where we unpack the essentials of human health, from exploring the unique needs of women, men, adolescents, and children to public health insights. With expert advice and real life stories, it is a pulse on better living for every stage of life. Today's Lifeline Dialogues is taking a look at the Social Health Authority. Since its rollout on the 1st of October, what has been happening? Have patients been able to register, seek care? Have providers been able to see patients when they come in up to the point when they walk out? What is the state of maternal health, dialysis, cancer care? What is happening to primary health care? And most importantly, what about emergency care, which is a constitutional right to every Kenyan? Joining me for this conversation is Dr. Brian Lishenga. Dr. Lishenga is the chair of the Rural Urban Private Hospital Association. They have been taking quite an interesting look at the Social Health Authority. From the 10th of October, they've been asking their members, who are healthcare providers across the country, on 18 different metrics to answer on whether SHA has been working as envisioned. Have they been able to log in? Have they been able to register patients? Have they been able to get authorization? And at the end of all of this, they've been giving SHA a scorecard. Currently, SHA is not doing so well. It's at 47%, but it is an improvement from previously when they were at 19%, which is a straight E for anyone who has really gone through any education system. So Dr. Lishenga is here to just delve deeper into that conversation and let us know what has been happening to SHA. Karibu sana daktari. Daktari, over the last 6 weeks of the Social Health Authority, what, in your opinion, has been the impact, successes, or challenges that have been observed by your members and also by the patients?
Okay, so thank you for having me on this show. So obviously, over the last 6 weeks, it's been a mixed bag, a roller coaster to say the least. We, got off to a very turbulent start. I would say the first 14 days were extremely difficult. And, it was coverage about patients missing care and providers essentially not knowing what to do. So I would say the first 2 weeks were the hardest. And then the issues that were really important started coming to the fore after week 3. So for the last 3 weeks, we're in the 6th week. For the last 3 weeks, I see a more concerted effort to address the specific pain points. And what we have been doing as an association is to analyze the situation as objectively as possible so that we can also give the kind of feedback that allows for transformation to happen. Basically, filter through the noise and get to the actual matter.
So what went wrong in those
Initially,
first 3 weeks, or even the first week?
I think what this is a very interesting question. So transition management is 2 words that come to mind. That this was like switching off a light switch, but essentially this was not that simple. It was more like switching off an entire plant. So, you can imagine switching off an entire like reactor or nuclear station or something. It can't be just one switch. But there was a perception that, we could just turn off one switch and the next day we would be in SHA and NHIF would be gone. But NHIF has been with us since 1966, so that's extremely a complex thing to do. So what went wrong was, one, we had an untested provider portal that was supposed to handle transactions between the social health authority and healthcare providers. It had not been tested in the real world. I've been involved in software projects. When you test it in your back office, it looks excellent. Everything works. But then when you put it in the real world environment and users are interacting with it, collapses. So that was one of the things.
My conversations with the teams in SHA before the rollout was that they had tested it in some facilities and it was working. Or what test were they talking about?
I would say this. Not any facilities that I know of. But then again, that was controlled environment testing, where you are, even in terms of troubleshooting, it's real time and you have enough resources to troubleshoot for 3 facilities if you're testing. But now, by their own admission, NHIF had 8,800 facilities. And with SHA and the new laws, as long as you're empaneled by KMPDC, you can be contracted. So that number has ballooned to something like 12,000, 13,000. Now, onboarding those ones overnight and getting everybody. So you have 4,000 facilities that have never interacted with NHIF SHA, or NHIF as it is. Those are totally new players who have no background. Now you have to support them. Then you have 8,000 or so who have some level of interaction with you, but this is an entirely new system. Then you have 56 million Kenyans who've never interacted with this.
At all.
So if you combine that multiplicity of issues, you realize that this was not a walk in the park. This was something really difficult. And I think personally we should commend them because, given that complexity I have just described, things could have been definitely much worse. Yes.
Yeah. Okay. So now looking back, are we getting somewhere? Are there any indicators of successes, of improvements from where you sit and from feedback from your members?
So we started surveying the transition as an association on 6th of October. That's just within the same week the transition began. And we released our first score on 10th of October. And in that score, we have 18 metrics that we've been tracking to see how the transition is. In that first survey, the score came out as 19%.
That's an E.
It was like total failure. They were things that were so bad. Like patient verification. Who is eligible, who is not. In fact, even a worse one was how many providers can actually simply just log into the portal. When we started, that number was less than 10% when we started tracking. So our very first score was 19%. And a lot of, even the 19% was based on what I would call non-core issues that we were tracking. Our last survey, which was on between 9th and 12th of November, so just about a month later, shows that that score is now at 47%. Now, if you have a student scoring 47%, it's a promising student.
It is still an E.
This is a student.
This is a D.
Yeah, it's a D, but if it is term 1, they have room for getting there by term 3. So from 19 to 47 on the same metrics is quite an improvement within 4 weeks.
Where have been the greatest improvements?
So the greatest improvements has been on how many providers can access the portal. So when, as I said, we started out was less than 20%. Our last survey recently showed that something like 94%. So it's only 6% of providers who have not received credentials to date. So literally everyone we are asking says, yes, I have credentials. And among these 6%, you have those ones who are totally new or those who are just skeptical, who are not taking it up. So some of those issues are not SHA controllable. Within of course, if you go granular, within the 94% who have credentials, you tend to find problems. Like we found that about 30% of them have issues from now and then, like automatically being logged out, or at some point the portal is sluggish and you can't access for hours on end. So we do have those, but the fact that almost every provider who wants to have credentials has them. That's been a massive improvement. Something else that was really difficult in the beginning, you remember the issues around dialysis and chemotherapy,
And cancer care.
oncology care. Of course, those ones got a lot of coverage because of the, let's say, risk of mortality around those two conditions. But there are many other conditions where patients needed urgent care. And pre-authorization was impossible. When we started out, people didn't know how to go about it. But ultimately, dialysis and chemotherapy were sorted out really quickly within a week. After the coverage and the outcry and of course human rights issue. Surgeries followed, and so there was progress on surgeries. And then after that, maternity followed. So we've seen the growth like this from dialysis, which was the very first one to get checked, and then oncology followed, and then surgeries followed, and then maternity followed. What is lagging right now is outpatient care. So outpatient care in our latest survey still scores the poorest. We still haven't, so that's still a pain point.
Why is it so? I thought from what SHA described, outpatient services would be at level 2 and 3. But the other day I saw a circular from the acting CEO that, some level 4s who would be interested in offering outpatient should apply. So I thought the level 2s and 3s are already known based on the KMPDC list, the Kenya Medical Practitioners and Dentists Council list. You already know level 2 and 3. So shouldn't it be obvious? Because also what they need to be reimbursed per person on capitation is also known. So what is the challenge?
Okay, very interesting. So what's the challenge? One, that's level 2 and level 3 care, primary health care, is dominated by public health facilities across Kenya. Our network of private providers does participate, but if you were to look generally, public facilities dominate primary health care. In some parts of the country, faith-based hospitals do, like the northern frontier areas. So what have we found out? Because we get secondary information from our providers about their interactions with the public health system. And what we found out is let me explain how we get this. There's a referral system now that you are supposed to send patients from level 2 to level 3 to level 4. A lot of private healthcare providers are at level 4. So they expect patients to come to them from the public level 2s and level 3s. Now, what they observed is that, one, many public level 2 and level 3 facilities are not digitized. So no computers, no internet, no power backup. Many of them close by 4:30 every day. Every single day, and they don't work over the weekends. They observed that many of their staff are not computer literate. In some cases, when we had training, now the initial training, and which is still another problem, initial training around the SHA portal was entirely virtual.
I remember even participating in some of those trainings.
It is still even virtual now. Although we have noticed a trend in the last 2 weeks of local SHA officers getting more involved, because even them, they were playing catch up. They didn't also know a lot of things about that new portal. But the trainings were virtual. The facilities don't have IT, digital solutions. The staff are not IT literate. So they didn't know when the trainings were happening. And when they got to know where the trainings were happening, they have to travel 20, 30 kilometers to maybe the county headquarters where the training is happening. So we have a complete break on how to onboard the vast majority of level 2 and level 3 facilities. A few counties are doing extremely well. The counties which were digitized, for example, Murang'a. Murang'a is one of those which didn't have a problem with digitization. But this is not the same everywhere. So that's one. Primary health care started to collapse because our level 2 and level 3 facilities at a human resource level and an IT level were not ready. And at training level, we could not onboard them. And now you can also take that towards even private and faith-based. Then the second issue around them was the unclear rules around reimbursement. I know you mentioned that 900 bob is known, but if you look at what has been gazetted, the gazetted tariffs talk about primary care networks, PCNs, and that you will be reimbursed at based on the number of patients you've seen and the nature, the weight of diseases that presented. It's a very complex thing. So for many providers, they still don't understand what primary care networks mean and what population level reimbursement means. It's just not clear that who is eligible for care. Now, our colleagues at SHA would say the primary healthcare fund pays for all Kenyans as long as they are registered.
That's what they've been saying.
Yes, well and good, but who is registered? If you look at our survey, you find a common problem has been just getting people registered. And there are many issues around that. One is a database issue. There was the issue of migration of patients from the NHIF database to the SHA database. What happened, as what we have noticed, is that principal members were migrated, but their spouses and their children were not.
So the dependents were left behind.
So the dependents were left behind.
So somebody has to, because even the registration, I was up country recently, and the registration has to be done on the website.
Yes.
And people back in the rural areas don't have access to the website.
It's a major challenge.
Yeah, so they can't onboard their dependents if they don't have access to the website.
Exactly. So, afya yangu, I like the ideas. Everybody thinks the ideas are great. We want to get digitized, everything is online. But the ideas are very 21st century, and a lot of the country in terms of digitization is still 20th century.
So are your members, the private hospitals and even the public, being involved in onboarding patients when they show up for care?
Yeah. And to the credit of hospitals across Kenya, they complain about things, but when a patient comes, I have not seen them turning away patients. They are helping patients register. But remember, the extent to which you can help is knowledge. You also must be familiar with the registration process. Or now look at the burden. In fact, we got this a lot from level 2s and level 3s. They said that the shifting of the registration burden to us is straining us, because some of these facilities have one person at the reception. They don't have the luxury of dedicating HR for the registration function, but they do try. And then, they ran into other problems like OTP delays.
Yes, I've seen that, and I've experienced it myself, where it says it's coming in 2.5 minutes.
And you are there.
And you are there for 15 minutes, and there's no OTP.
We've seen patients sometimes 24 hours. Sometimes a patient waits for 3 hours, and then they say, can I just pay cash? So this has been part of also what has been driving out of pocket payments. So the hospitals have been helping people register, but the registration, is difficult because of dependency on internet. The IT dependency, you have to go to a cyber cafe, etc. People give up at that point. Now, remember, when we had NHIF, in 2021, we completely moved towards fingerprint biometric. There was a lot of investment in that biometric infrastructure. Hospitals also spend money to buy biometric readers and things like that. There was a lot of hue and cry. I think even people went to court about this. The then NHIF spent quite a bit of money in the new HICS system. And we spend a lot of time collecting biometric data nationally. Now, here's the problem. We migrated, 12 million principal members from the NHIF database, but we haven't migrated their fingerprint data. This would have totally solved the problem. So we have, I don't know whether, you see, the one-time PIN has issues other than what you said, the delays. Secondly, some people don't even remember the phone number they registered with. As NHIF principal, did I register with 070? I can't remember. It was 5, 6, 7 years ago. If they are elderly, Maybe it was the daughter, the son, somebody who registered.
They can't remember which
They
one.
can't remember which one it was. Sometimes you have spouses who work in different parts of the country. Husband works in Garissa. The wife is in Busia. The guy has to get the OTP to send you the OTP. He's not aware that you are in hospital. So we have, and then also the possibility of fraud. The fact that you can actually generate OTPs for people who are not physically present in the hospital seeking care. And so this entire exposure has led a lot of providers to say, let's take a break on this. So we have, if you ask me, you asked me primary care struggling. Primary care is struggling because we can't register people, we can't verify people, we don't know how, hospitals are not clear who they should treat and who they should not. And remember, we are coming into this environment with a lot of pending bills. Now, we are now in the October-December quarter. Ideally, now we are in mid-November, ideally by now, primary care facilities should already have received money to offer services. The last time they got money was in August. Now, they are running on fumes. These facilities, they just don't have the money. The supplies are not available. If you ask them now, everyone who is registered can get care, they are feeling overwhelmed. So
just to be on the issue of reimbursements, the feeling that I get is that the facilities across the country are like dependent fully on SHA now, previously NHIF, for their day-to-day running. It's like their business models are dependent on this, such that if there's no money, like you've said, then they are running on good vibes and fumes, you know? Isn't that even just dangerous for a business to have one line of revenue?
okay. We have to understand the country. It's a good point. But the vast majority of Kenyans live on less than $2 a day. Many Kenyans in rural areas are still poor. I ran a facility for a while in Joro, and I had no NHIF, I had no private insurance clients, and clients for who could pay cash were very few. In a country like Kenya, you cannot make a business model on private insurance or cash paying clients for the vast majority of people. You actually have to have social protection. So it is not that the hospitals are making wrong business choices. It is that the hospitals have only one business choice to make. And that business choice is social health insurance. If we don't have social health insurance, then out-of-pocket payment. You and I know that if we do out-of-pocket payment, one, Kenyans, people will die.
Yeah.
And two, poverty will increase. Catastrophic. You know, those WhatsApp groups for
Wichanga,
that's going to be our way of life. So, and I'm just saying rural Kenya as an example, but even in Nairobi, you have areas in Nairobi where you cannot sell private insurance because of
you have
poverty.
the urban poor.
You have the urban poor, and it's quite. I saw a report recently that Nairobi actually has more urban poor than Kiambu, for instance, So the reality of the matter is that a lot of people in our country still are one disease away from poverty, and social health insurance must work, and we need to support it to work. Otherwise, people will remain poor and people will die.
So do you think, like you said, the social health insurance must work? So do you think if it works, it will work for you as a provider and for me as a patient? And how?
So one of the things we have never gotten right is, and I hope we will, is how to correctly price care, to correctly price care. So right now, if you ask hospitals, they will tell you a capitation rate of 900 per person per annum. It limits the kind of care I can provide. And within that capitation price, you're being told ultrasounds are covered, x-rays are covered.
Everything, literally.
Everything is
For
literally.
primary care.
I saw the circular. ANC, antenatal care and postnatal care is also covered. Now, your knee-jerk, if your knee-jerk response as a provider say it's not possible. I mean, it's not even how,
But isn't the premise of capitation based on the fact that not everyone
will fall sick.
will fall sick, not everyone will seek care? So if you take antenatal, for example, Kenya has, say, 25 million, almost 27 million women. Out of these, in any particular year, 1 million will be pregnant. So there's capitation budgeted for the 27 million, but out of these, only 1 million will seek antenatal and postnatal care.
Yeah, and that is what it should be. Unfortunately, that is not what is. The capitation works at a population level. So, because then you ask yourself, how many are young and healthy in my capitated list? And so you transfer the risk of insurance from the insurer to the provider. So it has a lot of advantages if it is actually capitation. However, part of the confusion was that it was not properly defined if that was going to be capitation, or as I mentioned to you, what they were proposing, which looks like a fee-for-service payment. Like you say, how many patients came to Dr. Mercy's hospital? How many of them were diabetics? Then you calculate and you say, for every diabetic, I will have a factor of 0.9 on the reimbursement. For every Homer, I will have a factor of 0.5. That's not
So
capitation.
that's the weighting they were talking about.
Yes, that's not capitation. Capitation is agnostic. You see, capitation is agnostic to the diseases and the numbers of visits. Once you start introducing what disease the patient was suffering and how many visits came, you are now talking about a fee-for-service reimbursement. So that confusion caused people to step aside. But let me put it this way. If we have capitation defined as a fee paid per head for an entire population, regardless of whether they show up in hospital or not, and then you let the healthcare provider then manage that fund themselves, then that might work. This is what we are saying. If you have a population of 100,000 and you capitate all of them, you will be capitating 90 million per year. And then you ask yourself, so this population, where does it live? It lives here. How many level 2s, level 3s are there? And then you tell these level 2s or level 3s, this money is your money to take care of this population. Don't turn anyone away. Don't ask anyone to pay money. Don't take any, out. This way, it makes sense.
It makes sense.
It is possible. Although there are arguments, people will say, okay, if I have an X-ray, maybe I have more patient load. We can talk about things like that. But essentially, population level capitation can work, especially for a country like Kenya, where it's a majority young population that is healthy. It can work. What has not been happening is that what I am describing hasn't happened. And you know why NHIF capitation didn't work? NHIF capitation didn't work because it was not true population-based capitation. It was riddled with adverse selection because everyone who had an NHIF card was sick.
Would seek care in the next few days, even, or weeks.
I mean, we have a few guys who are mandatorily contributing because they are employed. But the vast majority of the self-employed who are taking NHIF cards actually knew that the reason why I keep my card,
because I need to claim.
Yeah, and because I know I'm sick, I am diabetic or I have arthritis or I have a sick child, so let me be paying my card. So you had the pool that was paying was actually sick. So when you are running a capitation model in your facility, you had super selected for a sick population. Therefore, I don't know any hospital that was running sustainably on the previous capitation. Our hope is this, that what we are talking now, universal healthcare, that we are now in a universal healthcare time. Our hope is that when we say 900 bob per person per annum, It is 900 bob for every Kenyan citizen.
We should be the 56 or so million.
Of us. And in fact, we know that we need to allocate 45 billion shillings for the current population. And even if you say we will start with 80% of that, we are talking at least 30, 35 billion shillings. Part of the skepticism is the fact that the last appropriations bill allocated only 4.1 B. The argument is we will change that number once people register and we know how many Kenyans are registered. But to be honest,
capitation should be population based.
Yes. It shouldn't be like you're waiting for guys to register to allocate the money. It's for every Kenyan. So just put the money there and then say, these are the hospitals where you can go. Walk in tomorrow. We promise you, we will pay the hospital. Okay. That's it.
Doctor, have you seen any improvements, say in, or any, let me call them any changes, because it could be improvements or, a decline in terms of the patients coming to the facilities, the demand for services by the patients? Have you seen any changes since the introduction of SHA?
So one of the things that we've noticed, Doc, is that the level of public skepticism to SHA is extremely high. This is something we started tracking on our last survey. We were not asking about it before, but it was triggered by a question we asked on out-of-pocket payments. We wanted to find out of 10 patients. The question was very simple. We would ask providers, out of 10 patients who come to your hospital today, how many end up spending cash, paying for something out of pocket? And what we found out was the number was like 11 out of 20, so something like that. Out of every 20 patients, 11 will spend some money out of pocket.
More than 50%.
More than 50%. And we also, and we intend to do this more on our following surveys. We also try to find out why. So why are patients paying out of pocket? And a recurrent theme was outpatient care. Now, in two ways. The one I have described about level 2s and level 3s and capitation, but also at level 4, 5, we don't have any level 6, but we have 4, 5s in our network. At level 4 and 5, the fact that they do not treat direct walk-in outpatient. So what has been happening is patients walk to their nearest hospital, which is a level 4 or a 5, and they are told, we cannot offer you direct care because we will not be compensated for it. So they would tell the patient, you can go to hospital X or Y, which is a level 2 or 3, to sort you out.
Or you pay.
Most patients will just say, I can't.
Because they have come all the way here.
All the way, and some of them, this is their regular service provider. So they would just say, let me just pay and get the service instead of, because I trust your service, or we have a relationship, or the other place is too far, so I just pay. So that is one. The other one was the one I told you, missing dependence. You are a mother bringing a child. The child is not in the system. The child has a fever. Is the mother going to go around looking for what is the level 2 or level 3 next to be sorted? They just say, okay, treat.
How much?
How much? So the fact that the portal was not ready and not showing everyone also contributes to out-of-pocket payments. One of the misleading narratives that has been there is that facilities are generally deliberately charging. And I think that's a wrong narrative. Facilities are not deliberately charging in a quote-unquote way to punish the government. There are so many factors around why. And in fact, patients themselves voluntarily saying, let me just pay instead of suffering the inconvenience. Or my kid is not there, the process of updating the beneficiary, the dependent details, the OTP is delaying, this kid needs care, let me just pay.
Do patients know what their entitlements are, what they need to do, the registration? What's the level of awareness of patients that you see, or the public really, about what their role is and what they need to know about SHA?
So, if I had a chance to talk to the peers or the CS or the SHA people, I would tell them that you have a major communication issue, a major communication issue. First of all, if you look at the political environment over the last few months, from the impeachment of the deputy president to, generally just...
It's been hostile.
there was Adani Airport.
It's been hostile.
So the vast majority of information that's gone out to the public, and I'm using that to just show it's not healthcare information only. The general deficit in trust between the populace and the government is very wide. So there is, and this is what the feedback we are getting is the level of distrust. So that people are shying away from even registering voluntarily. And I'm happy that there has been transparency in showing the registration data. And nationally, it's very low, the uptake. And they should be asking themselves, what's the problem? Right. The problem that we're getting, it's multifaceted. One is, of course, many people just don't know, because information gets to people very differently. But a key one is that there are people who know and are just choosing not to participate. And the reason why they are choosing not to participate is they are skeptical about the whole reform. They don't trust the government. They don't trust the carrier of the message. You have a whole bunch of people who still think their money is in NHIF.
Yeah.
I used to pay NHIF and I never got anything from there. Now you are asking me to pay this new one. So government has a messaging problem. I think what I would propose is that you have a multi-stakeholder approach. You get government officials, that's fine, but don't let them be the only ones talking to the people, because the people don't trust. It's a question of shooting the messenger. This messenger is not trustworthy. It's
not trustworthy.
So if you could get other stakeholders like
the KOL, key opinion leaders within different communities.
You get the Kenya Conference of Catholic Bishops, you get RUPHA, you get CAF, you get Kenya Healthcare Federation, you get all these guys who are, quote unquote, respected voices. Let them be the ones going to the communities and telling the communities, hey, this is the nice thing about the Social Health Authority. This is why you should register. I am told, part of what I'm hearing is that the using of the former provincial administration, the chiefs, and, the county administrators, is not making things better. It's actually making things worse. Because some of them are literally going to tell the public that it's criminal for you not to register. And then there is also misinformation. There's a lot of a narrative we are hearing is that your data is being gathered for some use. They are checking your M-Pesa transaction. This one came out actually because of the proxy means testing. Because, the number of questions people are being asked before your premium is determined. Yeah. There is now a narrative coming along that the government is trying to know too much about us. How many cattle do you have? Why does the government want to know how many goats?
Which kind of house
how
do you live in?
How many goats I have? How many my house? So,
did you build it?
Yeah. So we need to tackle the disinformation, and we need to have a deliberate campaign to win public trust, and so that people can see. The other thing I noticed is that two people registering, and we had this from quite a number of facilities. So you have two people who are neighbors who come in and they are not registered. So the facility says, okay, we can register. You go to that desk. So you go to the desk, they start registering, and this is your neighbor. And then at the end of it, the proxy means test says your premium Mercy is 500. Your premium Brian is 2,000. And I'm like, no.
But we are neighbors.
Like
living in the same conditions.
She even has more goats than me. So you have people who, once they get their proxy means test result, they just opt out. They just say, no,
I cannot pay
I am not ready. And remember, these are people who used to pay 500 bob. Now, when they get a result that says pay 1,000 bob, you can see what the problem. So we have a messaging issue.
But I've also seen, Doc, a situation where I was in personally. Somebody was giving their own experience about SHA, where they went to a facility. They needed a surgery that was 145,000. They literally walked in, had the surgery, and walked out without paying anything.
Yeah.
But them trying to say that they got booed, and people are like, no, you're lying. So how else do you communicate or say anything positive or anything that has worked, yet the recipients of the message don't want to hear that it can actually work or it has actually worked for somebody?
So our survey shows that 71%, 71%, 70% of facilities are able to claim for their surgical claims, etc. And also, we saw some bright lights around pre-authorization. So, for example, our report shows that for many facilities now, pre-authorization is almost seamless.
Yeah.
Unlike before, where you'd get somebody interfering, say that surgery you said of 145,000, that is the contracted sum, and you'd get somebody approving 80K. And then hospitals will be wondering.
But
this
it's
is my
gazetted as
contract.
145,000.
What's happening? So what we've seen that is, and we hope it stays that way, is that approvals as per gazetted tariffs are happening. Approvals are almost seamless. And once claiming process, and I would say this, for surgeries, for dialysis, for oncology, and recently for maternity. That is the experience we are seeing. There are some glitches. Like, for instance, somebody says they are worried that if you have a typo, a procedure for 140,000, and somebody writes 1.4 million, 10, the portal approves. So there are people wondering, wait a minute, are we going to end up in some audit thing happening?
Yeah.
So that's part of the feedback we are giving. But generally, I think that's working. I will tell you where the hue and cry is. And I've already described it, if the Social Health Authority can fix primary care, which we've spent a bit of time talking about, if they can fix primary care, the level of public outcry will suddenly drop drastically. Because you need to remember, they fixed dialysis. How many patients in Kenya are on dialysis? A few.
0.17%.
Yes. Very few. So it touches, it saves one life, 2 lives, 3 lives. But in terms of population impact, it's a very small issue. How many patients require surgeries? I saw the data. We don't do more than 300,000 surgeries a year. It's not many patients.
Very few. It's just that the impact is big.
Yes. So for the one life you save. But if you're doing population level policy things, you need
primary
to
health care.
sort primary care. The day we sort primary care in this country is the day we are now on the right track as a nation.
Is SHA receptive, even just to your surveys and the feedback you're giving? Is it receptive to adjusting? Because, policy should be a living document. So if they have seen that this is the way we intended SHA, but the feedback we are getting says otherwise, are they receptive to being adaptive to the feedback you're giving them?
So one thing I would say that, even we ourselves as associations, we are not perfect in any way. We've also been accused in the past of criticizing without information. Like we don't know the inside story. And one of the things that we are deliberately doing is to make our feedback more objective and more data-driven, and in a way to rebuild the trust relationship between associations and the government. Sometimes it is felt that when we point out things, it is direct opposition. But I would say what I have noticed recently is that even our surveys are being positively received. Not always, they are. You see, when you get let's say a cabinet secretary telling you, I read your report, it's positive.
Yeah.
That's progress. So the openness on the government side is something that we have to commend.
It's improving.
It's improving. I would say that they definitely, as time goes by, they need to build more resilience for receiving negative feedback. That's the part where I think this particular leadership is weak at. That negative feedback really hurts, like it's taken so badly. If you say, like if you say OTPs are delaying, it's like you're saying you don't want this reform. This is not a reality. So we, I hope, I hope that they listen and they implement. It's they should not only, I know they are thirsty for good news, because there's been so much negative news recently. But it is in the solving of the difficult issues that the good news is going to come.
What has been the role of media, in your opinion, in everything that has happened over the last 6 weeks since SHA was rolled out?
So the media has been first.
We can take negative
You
criticism.
guys will have to take this one. So first, to commend the media for keeping this conversation alive. I think there has been much more reporting around SHA, the reforms, than around many other subjects. We got a bit distracted by politics for a good chunk of, but I think generally there has been focus there. What I find that is missing is not so many people in media who really know the details, who really understand what the reform is about. I struggle to meet media practitioners who know what a rebate is, for instance, like inpatient rebate. What is that? So we do need the media to invest in technical capacity around the issues. And then sometimes we've also seen false reporting. For instance, if you take our survey that came out the other day, we were trying to say primary healthcare is suffering, but what the report ended up saying was that level 2s and level 3s are ill-equipped to see patients. Now, what then happened was an outcry in the opposite direction, where now everybody was saying, Fungweni level 4s, we want to go there. You see, so our intention was to highlight that level 2s and level 3s are being ignored.
But basically, they need their reimbursements.
Yes,
they need the capitation spelled out.
So we're saying they don't have supplies because they have not been properly financed. But then how the reporting came out was that, gosh, if you go to level 2s and 3s, you will die. So so as a result, a lot of our members who are level 2s and level 3s felt betrayed by the report. But
that was not the intention.
Yeah, even worse was that the public was misinformed, because
so now people shy away from those facilities.
And now if we do that, what's going to happen to out-of-pocket payments? Because they're going to rush to level 4s.
Then it will go up. Yeah. So we have not helped the situation.
So I think on the media side, it's making sure that we report factually, because I think the intention there was to, I don't know. You guys in the media do your things.
I think people understand things differently, and they see, like you said, my level of articulating a story depends on my innate and actual understanding of the subject matter. So if I don't grasp it, then I will.
You cannot tell the story fairly.
Yeah. We interviewed Dr. Abdi just before the rollout, and on primary healthcare, he was very confident, that the primary care facilities would work, but we've discussed that in detail. So I want to go to the emergency care. How has emergency care been like? Because I remember asking him, it's open for anyone, whether you are registered in SHA or not. But how do you as a facility claim, say I come in as a non-African female, I'm unconscious, no documents, you need to save a life. How do you claim for that? How are you going about emergency care? Because it shouldn't be denied to anyone.
Emergency care has the same problem as primary care because of many Kenyans not being registered, many Kenyans not having their data available in the SHA.
But for emergency care, they said you need not be registered because it's a constitutional right.
Yeah,
Like
and-
if I get knocked on Kenyatta Avenue here and I'm rushed to the nearest facility down the road,
so
I should be seen
no,
within the first 24 hours and SHA should pay for
you
it.
should be registered. Maybe that's part of the misinformation problem we have. You should be registered. You just don't have to be up to date. You know, it is not contingent on you paying your contributions.
So say I come in
So
unconscious,
we
no
need-
documents. How will you know if I'm registered or not? And we are not using biometrics.
So we register you somehow. We have to register you. And I think that part of the problem of the emergency care, which it has to catch, and we need to rush to build a database of patients. You know, we don't have a database of who is a Kenyan. And I mean, if you look at reports published by even previous people, I saw a study published by the technocrats who were advising the Uhuru government, Uhuru Kenyatta government. They said that their primary problem was there was no patient database. Now, let me tell you why this is just a fact. If you don't have a database, I can claim anything. You get? I will just say John Doe came here, we wrote notes, filled in, and I sent it to SHA. How do you have to prove that there was no such guy?
It's impossible.
Impossible. So the reality of the matter is that facilities don't want to get caught up in audit issues. Facilities that do genuine work want to get caught up in audit issues because that patient is not visible anywhere in any register.
So how are you going about it?
So out-of-pocket payments are still happening for emergency cases. And it is not, and as I said, this is not an issue of the facilities refusing. The facilities are aware that until we have a stable patient registry database that I can tap in, even if it is linked to my ID, birth certificate, whatever, that I can tap in, it is impossible for us to actually submit claims that will be honored. And if SHA says go ahead and do it, people will go ahead and do it. But guess what we are going to be dealing with 3 months, 6 months from here? A bunch of hundreds of millions worth of claims relegated to an audit bin because they are not payable, they are not verifiable. It is the same issue we have around referrals. We say that, referrals between level 2, 3 and level 4, 5 going up. Right now, you don't have a referral system. So what's happening is if you have an eye problem, which is a primary healthcare issue, and you go to your local dispensary which does not have an ophthalmologist, the nurse or clinic officer, whoever is there, will write for you a note saying, query conjunctivitis, refer to level 4. Now, that is a piece of paper. That is the basis on which the level 4 is supposed to say, pay me because this patient was referred to me from.
It should be in the system, right?
How am I going to honor that if you are Abdi, if you're Dr. Abdi? Are you going to honor these pieces of paper?
I could have written it.
I can write it. In fact, here, we can gather here and write papers, refer each one of you to a clinic downstairs, and we claim.
And we claim.
So the problem with that is, and I guess what I'm trying to say is this, that there is 2 issues here. We have the provider portal, which is the front face. But we have a back office function, which is the database at SHA. I'm saying the database at SHA is either still in development and very early stage, or it's just non-existent.
So they still have a lot of work to do.
So yes, because I you see the front office, the SHA portal, it should fetch information from the back office. It seems to us that the back office it's just not there. It's not ready. The fingerprint problems we are talking about, the missing dependence that we are talking about.
But when you interviewed Dr. Abdi, he said there'll be no more fingerprinting because they're using, what's it called? Your ID. So no more collecting fingerprints.
Okay, fine. It's not a problem. But how many, you realize the problem with that? How many Kenyans without IDs? You know, like I was talking to providers in Narok. They were telling us that 60% of people who come for registration don't have IDs.
IDs because there's been a delay in IDs. There's a whole government issue.
So the
with
I I don't want to be in his position. You know, like I cannot imagine. I cannot imagine what's going through. But I think that for every Kenyan who has an ID or some identification document, the database should be updated yesterday. Those ones should not be missing. Let's now start talking about how do we deal with the millions of Kenyans who have no form of national identification. Those are our concern. Let me even make this even more interesting. Do you know we were talking to providers from now I'll not say this area because it will look, but teenage pregnancies. You can't providers can't claim.
Yeah,
providers can't claim because
they're dependents. Teenagers. They don't have IDs.
Now they are dependents and their principals are not registered. They themselves don't have IDs.
So those are three people in problems.
A total chain.
Yeah.
Now, even if you say Linda Mama is continuous, this is prime candidate for Linda Mama. You have no way as a facility to helping her. Maybe our colleagues at SHA know how to help, but there is an information gap between
There's an information asymmetry between SHA and yourselves.
And ourselves, and even worse, we can catch up, the general public. Yes.
Is SHA reimbursing, or has it started reimbursing facilities for services provided for the last 1 month?
No.
Because by 9th of November, I'm sure employers already submitted whatever they needed to.
No. We have one question number 18 on our surveys usually. What is the most pressing need that you think needs to be addressed for you to start, for you to treat SHA beneficiaries seamlessly? It's just open-ended. We tell providers, just tell us, in a perfect world, what will need to be addressed for you to be 100%. The number one issue for the last 4 surveys, payments. In fact, they even stopped talking about portal OTP
payments.
They just say pay us. So
has anyone been paid?
No single SHA claim has been paid.
The previous NHIF claims?
Now, on the previous NHIF claims, there have been attempts to settle claims, but we have a problem. The problem is shifting goalposts. It's like now, when providers listen to government, it's like you listening to somebody who owes you money, and this person keeps changing the amount of money they owe you. Like, you realize you are in a problem. Like
one day it's 30 billion, the other day it's 19 billion. So how much are you actually owed?
So you start thinking like, this guy doesn't want to pay.
But in your survey, Doc, you said some providers have been reimbursed.
So I'll tell you what has happened. Within the month of October, we were about 4.5 billion shillings was released. I saw another figure saying that it was 5 billion, but we're not going to split hairs. Somebody somewhere knows the truth. How much money? It's definitely not more than 5B. But
so who was paid?
All providers, public, faith-based, private.
So some monies
were paid. We did a survey around that. And what we found out was that 57% of providers got nothing. So you release, say, 5 billion, but only 43% got something. And we went a little deeper into that. We asked those ones who were paid, okay, so what fraction of your payables did you receive? And the vast majority, 68%, told us less than 10% of what I am owed. So now, you just look at that. So the issue you're saying is that the payments are irregular, the payments are too small, and the payments are not distributed fairly. So you have providers who are saying, I've not gotten anything since June, and I'm closing down. You have providers who are saying, fine, I was paid in September and I also paid in October, but I'm being paid consistently small amounts. You see, so these two problems, big issues. Now, remember, the SHA is accumulating debts every day. I think I saw their last number was like 3 billion or something. Now, even, if NHIF keeps, SHA now keeps paying at that rate of 5 billion a month, they're just going to be chipping off the 29, 30 billion debt by 2 billion shillings every month. It's still going to take, and if they do that consistently, it's still going to take 1.5 years to retire the debt. But expect that SHA claims will balloon eventually as everybody gets on board.
Okay.
I think what is required is the national government just has to retire the entire NHIF debt, because we know the vast majority of it was from parastatals and ministries and departments which were not remitting their deductions to NHIF. You and I, ordinary Kenyans, we do not have the luxury of not remitting our monies. So us guys don't owe NHIF anything. We pay it. So the top issue is money. Money. If they cannot be services without resources.
So it's really government owing the providers.
Literally owing itself. Government agencies owe SHA,
which owes
now,
the providers.
I know if you are the boss at SHA, how do you go tell the PS Treasury, give me money? This is a colleague. He knows you need money. So sometimes I feel like their hands are tied. That's where now, people like us, the media, and the associations, civil society, can help. And I think I consider our work helping SHA, because we can talk to Treasury differently from how they talk to each other. And we can tell them that you need to pay SHA, because paying SHA means lives are saved.
Okay. Now, how or what would you say are your 3 key milestones to track by end of year for you to say now SHA is working properly as envisioned?
So we need a reliable patient database. Once we get a reliable patient database, so that if you register your child, that registration should be logged in, say, immediately. And if you go for care anywhere in Kenya and you're a Kenyan citizen, we should be able to retrieve your data. So we need a reliable database. That's one. Number 2, we need to sort out provider payments across, and that is the old NHIF debt needs to be retired. Okay, and then 3rd, we need to fix primary care. So we get a reliable database for patients. We we pay providers, and we fix primary care.
Okay.
So if we can do those 3 things very well by December 31st, possibly, I think it will take longer. But for me, if the government was able to check those boxes, we will be well on our way to attaining UHC. There are many other conversations, people saying you are overtaxing a small fraction of the population, etc. The healthcare financing model we have used. I personally, don't concern myself with that too much. I think that as a country, we will one day decide how do we want to finance healthcare. Right now, this is how we are doing. For me, my concern now is what are the things we do to make sure that no Kenyan dies unnecessarily because of illness. And for me, it is to get a reliable database so that you can get care anywhere in the country, in whichever hospital, to pay providers so that they can get commodities and they can hire competent staff, and to fix primary health care, because that is where the vast majority of Kenyans get their care. If we do those 3, then later we can haggle about how are we raising the money. But those are the 3 things.
Okay. Is there transparency and accountability in SHA, especially now, because the funds that are being raised and the ones that should be allocated, for example, you said primary healthcare should be around 45B, it's at 4B, but is there some level of transparency and accountability in those funds from where you see it as providers?
No, I think one of the most opaque things around it's been an NHIF problem. I still see it with SHA is payment transparency, money transparency.
Like what you're saying,
Yeah.
on your end it's 4.5 billion.
Yeah,
Their
yeah.
end is 5 billion.
Yeah. This. I mean, there have been on and off attempts to be transparent, but it always seems like somebody pulls the strings behind. Payment transparency is critical. Money transparency is critical. Like, I'll give you an example. If you survey providers, they will tell you that. I think I already said that you have providers who their last payment was June, but you have providers who have been consistently paid
Small amounts.
If you pause there and you ask yourself, what's the magic formula?
What is the criteria?
Yeah, what's the criteria? Like, what am I? If I am in the group of June, what am I doing wrong? But if I am in the group of September, also, what am I doing right?
Right.
This is an unknown thing. And so it has led to these suspicions that there is a lot of human interference behind how payments or money moves around in the Social Health Authority, NHIF. That there are some people who are puppeteers who are pulling strings behind and saying, pay here, go there, do this. And we need to get to a point where we remove as much as possible human interference from the cash flow at the Social Health Authority. We need to get to, and one of the things I'm hopeful about the digitization is that it does that. That let's just get to a point where it is fast in, fast out. And if your documents are right, you get paid. That's where
so that it's fair.
Yeah, it's fair. It is predictable, and people can plan based on it. Yeah.
Okay. Thanks, Doc, for your time, for your valid input, and a lot of insights on SHA. We are tracking this SHA, the Social Health Authority, and just trying to pick a few sentiments from people around, people like yourselves, so that we see, are we getting in the right direction or not? And like we said, from where we started, from the 1st, 2nd of October to now, the sentiment it's getting somewhere.
We are headed somewhere.
Yeah, so we'd like to host you again, say in another 2 or 3 weeks, so that, we keep a pulse on this story. But thank you very much for your time, and thank you for being a part of Lifeline Dialogues.
Thanks for having me.
Thank you.